Welcome back to the channel. Before we dive in, I want you to picture this. A 58-year-old man comes into the ER confused, short of breath, and his blood pressure is dropping fast. Within minutes, he is surrounded by a team of nurses moving with quiet precision, adjusting drips, reading monitors, anticipating the physician's next order before it is even spoken. No chaos, no hesitation, just clinical excellence under pressure. That is the ICU nurse. And today, we are starting your journey into understanding what that world actually looks like. Whether you are a nursing student rotating through the unit for the first time, a new grad who just accepted an ICU position, or someone studying for NCLEX and trying to wrap your head around critical care concepts, this video is your foundation. For foundation. Let us get into it. Teaching point 1. What the ICU actually is and who belongs there. The intensive care unit is a specialized environment designed for patients whose conditions are life-threatening or who require continuous, close monitoring and complex interventions. Think of it this way. On a medical surgical floor, one nurse might care for 4 to 6 patients. In the ICU, that ratio drops to 1 or 2 patients per nurse. That ratio exists for a reason. These patients can change in minutes. The types of patients you will see in an ICU include those with respiratory failure requiring mechanical ventilation, patients in septic shock, post-operative patients following major cardiac or neurosurgical procedures, and patients with multi-organ dysfunction. The common thread is physiologic instability. These are patients whose bodies are fighting hard to survive, and they need a nurse who understands what is happening at the cellular level, not just what the monitor is showing on the screen. As a new ICU nurse, your first job is not to master every drip or every ventilator mode. Your first job is to develop your systematic assessment. And we are going to talk about that right now. Teaching point 2. The head-to-toe assessment in the ICU and the mnemonic that will save you. ICU nursing runs on structured, consistent assessment. Every shift begins with a thorough head-to-toe. And here is a mnemonic that will help you remember the critical systems to evaluate every single time. Use the word ventilatd. And yes, I spelled it that way on purpose. V is vital signs and ventilator, if applicable. E is eyes and neurostatus. N is nutrition and lines. T is tubes, drains, Foley's, chest tubes. I is IV access and infusions. L is lungs and airway. A is abdomen and bowel sounds. T is telemetry and cardiac rhythm. D is drips and drains, double-checking your vasoactive medications. When you walk into that patient's room and complete this assessment systematically, you are not just collecting data, you are building a baseline. And in the ICU, deviation from baseline is your earliest warning sign. That is when you act. Teaching point 3. Hemodynamic monitoring and NCLEX critical thinking. Here is where NCLEX and the real ICU overlap in a beautiful way. Hemodynamic monitoring is one of the most tested critical care concepts, and it is one of the most important skills you will develop at the bedside. ICU patients often have arterial lines, which we call A-lines, for continuous blood pressure monitoring and frequent blood draws. They may also have a central venous catheter to measure central venous pressure and deliver medications safely. More complex patients may have a pulmonary artery catheter, though these are less common now than they once were. Here is what NCLEX wants you to think about. If a patient's blood pressure drops and you see a low CVP, what does that tell you? It tells you the patient is likely volume depleted. They need fluid. If the CVP is high and the blood pressure is still dropping, you need to think about something like cardiac tamponade or right heart failure. That is your critical thinking at work. You are not just reacting to a number. You are interpreting a clinical picture. Always ask yourself, what is the trend, not just the number? A blood pressure of 90/60 in a patient who has been running 88/58 all morning is different from a patient who dropped from 130/80 in the last hour. Context is everything. Teaching point 4. Understanding vasoactive medications. You cannot talk about the ICU without talking about drips. Vasoactive medications are drugs that affect vascular tone and cardiac function, and in the ICU, they are running constantly. The big ones you need to know are norepinephrine, which is your go-to vasopressor for septic shock and works primarily by vasoconstriction. Dopamine, which depending on the dose affects different receptors. Dobutamine, which is your inotrope. It improves cardiac contractility, often used in cardiogenic shock. And vasopressin, which is frequently added as a second-line agent in refractory shock. The golden rule with vasoactive drips is this: they must run through a central line whenever possible. Because if they infiltrate into peripheral tissue, they can cause severe necrosis, and you never stop a vasoactive drip abruptly. You wean, you titrate, you watch what the patient does in response, and you document every step. Clinical Pearl. Here is the one thing that separates a good ICU nurse from a truly great one. Great ICU nurses trust their gut and then verify it with data. When something feels off about your patient, when their color is different, when they seem more restless, when a number that was stable starts to drift, you do not wait for the physician to tell you something is wrong. You begin your assessment, you gather your data, and you call with information, not just concern. Say, my patient's heart rate has increased from 78 to 112 over the last 2 hours. Their urine output has dropped, and their blood pressure is trending down. Not just, I think something is wrong. In the ICU, communication that is specific and timely saves lives. If this video helped you feel even slightly less terrified about the ICU, do me a favor and hit that like button. It genuinely helps this channel reach more nursing students who need it. And if you are not subscribed yet, join this community because we are building something great here together. Head to the link in the description to grab the free ICU study guide that goes along with this video. It includes the Ventil-ATD assessment checklist, a vasoactive drip reference chart, and NCLEX style questions to test what you just learned. Next week, we are going deep on mechanical ventilation, vent modes, troubleshooting alarms, and what to do when your ventilated patient suddenly desaturates. You do not want to miss that one. I will see you there.